Hello, this is James, and welcome to part 2 of our special podcast for World Benzodiazepine Awareness Day 2020. In part 1, we interviewed Angela Peacock, and we talked about her experiences of taking and coming off benzodiazepines, and also her involvement in the film Medicating Normal, which has a special screening and panel discussion on July the 11th at 1 p.m. EST. And you can hear that interview by visiting madinamerica.com. And before we go on, I just wanted to say that these podcasts would not be possible without the efforts of WBAD lead operations volunteer Nicole Lamberson, who goes above and beyond to make these interviews possible. So later in this episode, we will hear from Belissa Frederick, who is a therapeutic coach and psychotherapist with over 2 decades experience working with clients affected by prescribed drug injury. But before we chat with Belissa, I'm delighted to get the chance to talk with clinical pharmacologist Dr. Jim Wright. Jim is Emeritus Professor in the Departments of Anesthesiology, Pharmacology and Therapeutics in Medicine at the University of British Columbia. Jim obtained his MD from the University of Alberta in 1968 and his PhD in pharmacology from McGill University in 1976. He is a practicing specialist in internal medicine and clinical pharmacology. He is also editor-in-chief of the Therapeutics Letter, and he sits on the editorial boards of PLoS One and the Cochrane Library. Dr. Wright's research focuses on issues relating to the appropriate use of prescription drugs, clinical pharmacology, clinical trials, systematic review, meta-analysis, and knowledge translation. Dr. Wright, Jim, welcome. Thank you so much for taking the time to chat with me today for the Mad in America podcast. And to get us started, really, I'd like to perhaps ask a little bit about you and your background and what it was that led you to a career as a clinical pharmacologist.
I got interested in drugs in medical school, and I came to realize that a lot of the problems that patients had you could solve by looking at the drugs they're on and what might be causing some of the problems. And so often I found that I could solve people's problems by stopping their drugs, not by starting new drugs. And when I went to Montreal and was doing my internship in internal medicine, I decided to get involved in a PhD in pharmacology at McGill. And so I was able to expand my understanding of pharmacology and keep my clinical skills going at the same time. There was a strong clinical pharmacology program at McGill at the time. So basically, I've been interested in doing clinical pharmacology for the whole of my career. Anyway, I think most people don't appreciate that most doctors don't have a very strong understanding of pharmacology, and even pharmacists don't. I mean, pharmacists are very good at classifying drugs and knowing all the drugs, but they don't really understand the complexities of the effects of drugs in people. And it's a very complex field. So the more you know about a drug, the less likely you would be willing to take it, and particularly not on a daily basis. And that's really where people get into trouble. It's really just accepting and trusting and taking things. And it's amazing how people would research when they buy a TV or a car and look into it in depth, but they'll be willing to start taking a drug without learning much about it at all. So really, I think that's the big problem in medicine today is the drugs that people are taking on a daily basis that are having permanent or at least serious effects on their brain.
You used that phrase in some communication we had when setting up this meeting, and I was intrigued by that, because I haven't heard many pharmacologists be willing to say publicly that the more they know about a drug, the less they'd be perhaps willing to take it themselves. And I wondered if that was based upon your knowledge of the effects of the drugs on the body itself, or whether it's from knowledge of people's different experiences with some types of drugs, or whether it's a combination of both, really, that's kind of led you to that, to be able to say that so clearly.
It's really a combination of, so there's no drug that that has a significant effect in a person that doesn't have potential harms. And so we always need to be weighing the potential benefits versus the potential harms. And when you start to appreciate the potential harms, they're significant and often serious. But you can find that out by just reading the drug monograph, right, and looking at the adverse effects. If people did that, I mean, I think there would be less people willing to just take drugs. Yes, you can cause a lot of damage by taking the drug on a daily basis, particularly.
I've experienced myself, doctors, prescribers saying to me, don't worry too much about all the listed side effects because they're very rare and only a very small number of people get them. But, reading that list of adverse effects is quite important for informed consent, isn't it?
Yeah, it is. Yeah, and they often are rare, but they can be life-threatening, and so it's not something you want to do lightly.
Thank you. And you're a member of the Therapeutics Initiative, so I wondered if you could tell us a little bit about that organization and what it does and maybe how you got involved.
Yeah, so the latter part of my career, I was convinced to become the managing director of the Therapeutics Initiative. It was in 1994. And that led me into a field of research which is called systematic review and looking at the benefits and harms of drugs. And so I've been doing that and was either managing or co-managing director for 25 years. And in addition to that role, I was the editor-in-chief of the Therapeutics Letter, which is published by the Therapeutics Initiative and is freely available on the website. And those letters come out every couple of months, and they're usually kept quite short, and they're primarily for prescribing doctors, but there's a lot of good information for anybody who wants to read them. And we in the Therapeutics Initiative have a rule that you can't have any conflicts of interest. It's been that way since the very beginning. And so it's people who are looking at the research they're completely independent and not conflicted, and nothing to gain from the drugs or from any of the recommendations that are made. So in October of last year, after 25 years, I decided it was time for me to step down, and so I'm no longer the co-managing director. I'm still involved with the group and still on the steering group, but I'm not the co-managing director anymore, and that's given me a bit of a break. And I'm also not the editor-in-chief of the letter, which is also was quite a big job. So Tom Perry now is the editor-in-chief of the letter. And in January of this year, I retired from the university, and so I'm now Professor Emeritus. But I've stayed on as the coordinating editor or sort of editor-in-chief of the Cochrane Hypertension Group. So I'm still doing systematic review research. I still see some patients on 1 day a week in the clinic.
I wanted to ask a little bit about the Therapeutics Letter, which I found really, really interesting because, obviously as a consumer or as a patient, when you do read the official information on drugs, perhaps the package insert or information that your doctor has given you, you're never really sure of the provenance of it. And it very rarely includes any information at all from people that have taken that drug for whatever condition. It tends to be from the manufacturer's view of things. And the Therapeutics Letter I found interesting because not only does it present manufacturer-like information about drugs, but it also includes anecdotal accounts. That's something quite interesting that I've not seen before, because certainly in the UK and I guess in the US and Canada too, doctors sometimes tend to frown on anecdotal accounts of using drugs in this way. But to me, I think they're a fairly fundamental and important part of a rounded understanding of what the effect of a particular drug or intervention might have. So I was really interested to see that you use anecdotal information in your therapeutics work.
Yeah, not to a large degree, but when we were talking about withdrawal from antidepressants, there isn't much evidence, right? There aren't clinical trials in that area, or not very much, right? So in that area, the best evidence is actually anecdotal evidence. And when we get into adverse effects, also you often can't find very much good information in terms of the randomized trials, and so then you have to go beyond that and look at sort of observational studies and experience. But in general, what we've learned in the Therapeutics Initiative over the 25 years that I was there is that when you look into the evidence that is used by regulators to put drugs on the market, and you get into that in detail, we were, and we continue to be quite shocked by how weak the evidence is that the benefits outweigh the harms, and often it's a small, statistically significant difference between the drug and placebo, but not clinically very important, and I'm often surprised that it's on the market and we're giving it to people with that weak evidence. So that's the biggest thing that we learned. And then also we learned that the harms associated with drugs are often much more than we used to think. Because when we go into something, we have a sort of idea about it at the beginning, and by the end of it, we appreciate that the harms are much greater than most people think.
And I wondered why you thought it was that perhaps we don't have this rigorous scientific understanding of adverse effects and, the propensity for the drugs to affect people in a negative way. Is that because of the way that clinical trials are done on these drugs, or is it because we're not really capturing adverse effect data in quite the way we should? I wonder why we don't know more about the safety of these drugs now after many of them have been prescribed for sometimes decades in some cases.
It's mostly because there are very few long-term trials. So almost all the drugs get on the market with fairly short-term trials. So really, there's really only evidence for over short-term. But, what happens in practice is then people start to use them long-term and daily, and there really isn't any evidence in terms of the benefits and harms for long-term. And there's no incentive by drug companies to do long-term trials, and so we really need governments to be pushing for that and funding long-term trials so we can actually know what the benefits and harms are.
Yeah, and I guess long-term trials are technically difficult and probably very costly because it's technically difficult to follow somebody for decades of treatment, isn't it?
Yeah, but I've also argued that they're not that expensive if you do it, because we do track in administrative databases. We track hospitalizations and deaths, and so you can do actually large long-term trials without having a huge budget. And it doesn't cost very much to randomize people. So that's the key thing, is actually to set it up so that you actually randomize people and to come to in order to be able to come to some answers.
Thank you. That's really helpful. So since this interview is being shared on World Benzodiazepine Awareness Day, we'll focus in on benzodiazepines now a little bit, if that's okay. And I know you have an interest in benzodiazepines, so I wondered what it was that kind of piqued your interest in that class of drugs.
Well, we did a letter on benzodiazepines fairly early on. It's probably back in 96. At that time, we had got an idea of how many people were taking them in British Columbia. And it was quite surprising how many people were taking them on a long-term basis. And as you get into it, you realize, you appreciate that the evidence for the drugs is fairly weak, and that most people were taking it for sleep, probably for insomnia. But the trials that were done in those people were fairly short. And it seemed to help maybe a little bit in the short term, but even by a week or 2 weeks, they're probably not sleeping any better than the placebo group. But they got on the market based on that, and the monographs, as a result of that, say that they should only be used short term. So the problem with benzodiazepines is that isn't happening. And once you start to take it long-term, then you become tolerant. The drug is really not helping anymore, and over long-term use, it appears that we're learning more and more about the toxicity associated with long-term use.
So what would you consider then appropriate use of benzodiazepines? If I know there's been some guidance that they should only be prescribed short term, but I wondered in what situations you felt it was appropriate and then perhaps not appropriate to prescribe benzodiazepines.
The only way I prescribe them now is as rescue therapy, and I think that's the best term. And so I explain to the patients that if you take them regularly, they won't work, and but if you do take them as rescue therapy, they continue to be effective and can be useful for some people. So if a person is taking one for sleep, say 3 or 4 times a month, they can find it useful, and then they need to know when that would be appropriate. And so some people are able to use it in that way and don't get into any trouble with it.
You mentioned a little bit earlier that you'd kind of identified withdrawal issues from antidepressants and benzodiazepines as perhaps a particular area of concern and one where there isn't much scientific rigor. And I believe that you've kind of written about or perhaps discussed using methods of liquid titration to withdraw from benzodiazepines, particularly very slowly. So I wondered if it was possible for you to perhaps explain a little bit about using that method to come off them, and has it been more successful or less successful than other methods of stopping benzodiazepines in your opinion?
Well, I should just mention that in the last 10, 15 years, I have partly through meeting Heather Ashton and learning about some of the problems and the class action suit in the UK against benzodiazepine companies. I've gotten more and more interested in helping people come off of benzodiazepines, and so I've always used the Heather Ashton manual and that principle, and so I've been referred a growing number of patients with this problem and helped them to come off. And so what I've learned is that it's extremely difficult. Every patient that I've ever helped come off of benzodiazepines has described it as the worst thing that has ever happened to them in their life. And so that's something for people to think about. The principle is to do it slowly, 10% every 2 weeks, say. And one of the other principles that Heather Ashton promotes is that you should tailor it to the patient. And so when I'm helping people, we work out what works best for them. And so some people need to do it extremely slowly. And so it was actually patients who have introduced me to the liquid titration method. And they're the ones who have found it on the internet and have worked it out. But the principle is that you put a standard amount into a standard amount of liquid, and you create a suspension. They don't dissolve. It's a suspension, not. And then you can then pour off a certain amount and an increasing amount. And so you can lower it at whatever rate you want over a period of time. So, but they have to be careful in their, and they have to be willing to do it very carefully in order for it to work. But some people that works, and some people it doesn't. So it's not something for everybody.
And I wondered if you'd noticed a difference between people who may have tried to stop more abruptly and people that have used a gradual withdrawal method, particularly perhaps in terms of protracted or long-term symptoms or their need to kind of go back onto the drug to stabilize. Is titration a better option for people?
Titration is definitely better in terms of the success rate. If you do it slowly, they're much more likely to be successful. The people who do it more quickly or abruptly very likely end up back on the drug, and so they really haven't accomplished anything. But if somebody is off and they're doing all right, obviously you want to support that, and even independent of whether they did it slowly or not. And we don't really have good evidence that any particular rate of decrease leads to less protracted symptoms after you get off. That's something that somebody needs to really be researching. Yeah, we need to study this whole phenomenon of long-term adverse consequences of coming off these drugs.
And I wondered then, again, I'm sure the US and Canada are quite similar to here in the UK. You know, prescribers here, particularly I have to say general practitioners, so family doctors, really do not seem to know very much at all about the need to gradually withdraw people from dependence-forming drugs, particularly benzodiazepines, but also antidepressants too. So, you know, this is... You know, many people I've spoken with have had such poor advice to stop so quickly, and then they go back to their doctor in distress, and the doctor says it's relapse. You know, it's your pre-diagnosed condition. You know, the drugs being at fault is the last thing they think of. So, you know, how can we best approach the medical establishment to say, look, you know, certain classes of psychoactive drugs need to be tapered gradually, and probably for the majority of people that take them for, certainly above, say, a few months or you know, whatever it might be. Because I think the default at the moment is cut the drug by half or a quarter over a few weeks. And, you know, that causes some people dreadful problems, I think.
No, I agree. The benzodiazepines is kind of now being more accepted. College of Physicians in British Columbia actually provide the Heather Ashton manual on their website. There is a growing understanding of the problem with benzodiazepines. Hopefully, I don't know. We could probably, when I say we, the Therapeutics Initiative could look at prescribing over time, and we could see if there is some decrease in prescribing. But it probably isn't widespread. But at least I think there is some more appreciation that these are not good drugs to be taken long term.
Are there practical difficulties for people in titrating off benzodiazepines? You know, I know on the antidepressant side of things that liquid versions are available for some classes of antidepressant, but not all. You know, for benzodiazepines, is that similar? Is the liquid available for the more common variants and not for the others, or is it easier to get hold of for benzodiazepines?
I'm not familiar with convenient liquid formulations, no. So if you're going to do the liquid titration, you have to do it yourself. There are compounding pharmacists that will prepare drugs in precise amounts in capsules. And so sometimes we do it through a compounding pharmacist. The principle for benzodiazepines is to transfer to diazepam if it's possible, because it's longer acting and there are smaller tablets, and so so it's more convenient in terms of gradually reducing the dose. But the main thing, I guess, is for the person to become knowledgeable and find out what works best for them. There are some people who are very good at measuring it on a jeweler's scale and measuring small amounts and doing it that way. So there are a number of different ways that it can be done. Yeah.
When I first became aware of this world, I was quite staggered to find out actually how much people had to self-support and do this for themselves, because their prescribers were not aware really of the need to taper gradually. They weren't aware of any methods to do it. You know, they in some cases, unfortunately, weren't particularly supportive of the person trying to do it. So people end up, without doctors like you, Jim, who do know about this and who are willing to advise and to reference the Ashton Manual and encourage people to make use of that. I think it's quite an indictment, actually, that prescribers are so in the dark about this.
And they do, and they need support. So they need some people there to help them along the way. And the people who are successful also are more successful if they have a family support, a spouse or somebody who is also helping them. But it's extremely difficult thing. I guess that's one of the main messages, is that how difficult it is, and so you need people who actually can appreciate that and can appreciate that the symptoms that they're having are real. And but you're right. There are a lot of physicians still aren't knowledgeable about that.
Thank you, Jim. And in an article in the Chronicle Journal, you talk about how the brain has changed as a result of the drug in patients who have taken benzodiazepines regularly. And you also talk about withdrawal effects, meaning that your brain is trying to heal and readapt. So can these issues of physical dependence, tolerance and withdrawal be thought of as brain or central nervous system injury, especially in patients who go on to be protracted sufferers?
Yeah, I'm convinced that that's the case. We don't have any measure of it, and maybe someday there will be a measure of it, and then it would be help to be able to see why some people are having more trouble than others. But I'm convinced that all these drugs, that when you take it on a regular basis, right? So not if you take it intermittently, but if you take it on a regular basis, the brain does adapt to try and counteract the effect. And so that it is standard that tolerance does occur to all drugs that have an effect on the brain. It includes alcohol and any drug that is taken on a chronic basis leads to tolerance. And that tolerance is a change in the brain. And so when that drug is not there anymore, then the brain, that change is still there, and so it leads to symptoms. So I'm convinced that that's the case, and that it's a big problem for all psychoactive drugs. We know that it occurs, and we also know that it probably can be relatively permanent. Because we know that with antipsychotic drugs, people quite frequently develop tardive dyskinesia. And that's a neurological phenomenon where they have involuntary movements of their tongue or other parts of their body. And we know that can be relatively permanent. So anybody who says that drugs can't cause permanent effects on the brain are discounting that observation that is well known, has been known for I think 20 years or so. So likely these other things that people experience are almost certainly due to changes in the brain as well.
And is there any merit in pharmacological intervention for someone struggling with post-withdrawal effects, or does that just risk creating further complications?
No, I'm frequently asked that. And when I'm helping people to come off, they frequently say, well, can I take something that will make this easier? And my answer is always no, and definitely don't take anything that's acting on the brain, because that just is going to complicate things more. And there's no supplements or anything. So maybe someday there will be something that might help, but for the most part, anything is going to just complicate things. So you want to use exercise and getting the brain involved in mental activities to distract, and healthy diet and good sleep patterns. And you have to do all of those things. And then psychotherapy, I think, is helpful, but you have to be with a psychotherapist who's not going to prescribe drugs. So that's frequently hard to find. Most psychiatrists aren't willing to just provide therapy. So
there is a Vancouver benzodiazepine support group that lists you on their website as the only qualified doctor available in the Vancouver area who understands the implications of taking benzodiazepines and who understands and supports a benzo withdrawal program. So why do you think it is that so many benzodiazepine-affected patients have such a hard time finding knowledgeable providers such as yourself, especially after the problems with this particular class of drugs have been in the literature in some form since perhaps the 1960s?
I'm frequently asked if I can find somebody, and there are very few clinical pharmacologists in the world. Is one of the issues, and most clinical pharmacologists aren't interested in this particular area. I don't think there's a lot of money to be made in helping people get off of drugs. So that's one that is an issue. I've certainly exposed a lot of students to the problem and to patients, and so I'm hoping that some of those will continue on and with an interest in this area. But I guess that's the main reason. It's a difficult area to help people, but it's certainly needed.
At the University of British Columbia faculty and staff page, one of your research interests is listed as educational strategies to improve drug prescribing behavior. So, in your opinion, can prescribing behavior be improved where benzodiazepines are concerned?
Yeah, definitely. That's the solution, right? So if So all doctors now should be warning patients and only prescribing for short-term use or for rescue therapy. And they should just refuse to prescribe long-term. And there are more and more doctors doing that. And in British Columbia, there's the college is working to try and encourage doctors to not prescribe long-term. So there is some movement in that regard.
In a 2007 article about the Therapeutics Initiative, you said consumers should always ask physicians for evidence that drug treatments are effective and that nobody should take anything unless they've been adequately convinced that the benefits outweigh the harms. So it seems like this is a bit of an information minefield. So how can consumers go about trying to get hold of the information that will allow them to make the best choice for their long-term health and well-being?
The sad thing is that if you ask most prescribers, what is the evidence that this is a benefit, and even more important, if you ask them what's the benefit over the long term, they wouldn't know that there haven't been any long-term trials for virtually any of these drugs, antidepressants, antipsychotics, benzodiazepines. So the answer is no, we don't know whether the benefits outweigh the harms. And I'm growingly convinced that for many of these drugs, that the harms significantly outweigh the benefits.
Thank you, Jim. It's so heartening to get to talk with someone who acknowledges the risks and takes such a careful and cautious route to prescribing, and also someone willing to help and support those who have suffered iatrogenic harm, even though they followed their prescriber's instructions to the letter.
I'd like to just mention that I think Robert Whitaker is doing a great service to society through his book and his attempts to enlighten people about the whole problem. So we need to encourage people like him as well. But Anatomy of an Epidemic, I recommend to all my patients to read. And I do think it is really an important epidemic that we need to be aware of, and that is almost certainly being caused by drugs, not helped by drugs, but actually caused by drugs.
Thank you so much for your time, Jim. It's been great to get to talk about some of these issues for World Benzodiazepine Awareness Day.
Okay, thanks a lot. Yeah, take care.
So I just want to thank Jim for taking the time to chat for the podcast, and you can find out more about his work by visiting the website of the Therapeutics Initiative, which is www.ti.ubc.ca. And thank you to you all for listening, to all of you for sharing your stories, and for everyone involved in making World Benzodiazepine Awareness Day the incredible event that it is. So until next time, take care.